All right, so welcome everyone. Today's a really exciting day because we have a POCUS clinical reasoning session with the one and only Dr. Dan Restrepo, who I'm sure the VMR audience knows him very well. He's come on for POCUS sessions and clinical reasoning sessions. But Dr. Restrepo, thank you so much for being here today and presenting a POCUS case. Do you want to unmute and say hi and share any recent updates in your life?
Hello, everybody. Thanks for the opportunity to be here. Thanks for the invite. Things have been great. Things have been busy. I'm excited. I was telling the team before we entered the room, this is a relatively fresh case that I saw back in December. And it was a great example of augmenting clinical reasoning using point of care ultrasound. So I thought I couldn't resist the opportunity to present this case to everyone.
Awesome. Yeah, we always love the POCUS VMRs. We've had a few in the past and it had been too long, so we're all really excited for this. Deborah and I will be co-discussing the case along with Ravi. And Deborah, you want to say hi?
Hi, everyone. I'm excited for being here. We are back with our POCUS VMR. Thank you, Dr. Restrepo, for being with us. And yeah, I can't wait. We are going to have a first section this week and another one next week. And Ravi, how are you?
Oh, absolutely great. Wonderful. Thanks for inviting me on. And I'm also really happy Dr. Dan Restrepo made some time to bring a POCUS case. Not only is he a great friend of CPS and does run some of the Monday evening, the clinical reasoning expert presentations, but he also does contribute to POCUS VMR. So I'm very excited to have him here, and he brought a case, and hopefully we all learn something and at least take away some POCUS skills that can help us in our clinical reasoning. Back to you.
Continue to use that term expert pretty liberally, but I appreciate it and I'm happy to be here.
Great. Shall we start with a case? Maddie, you want to, yep, or whoever can deploy the screen
let's
here.
do it. I think Yasmin is scribing. All right, I think we're ready for the first aliquot.
Awesome. So we're going to do this live. I think when it comes to the images, I will just I have some slides pulled up with the representative images. So maybe I'll just commandeer the screen at that time, if that sounds okay with everybody.
Yeah.
All right. So I saw this patient actually on our medical consultation service. So they were not admitted to a medical service. They were actually admitted to a neurosurgical service. And they had actually had a fall, hit their head, and had a subarachnoid hemorrhage that was being managed non-operatively, and we were called for pre-syncope. So the chief concern here would be pre-syncope that actually led to a subarachnoid hemorrhage. So this is a very functional, very vibrant, amazing 91-year-old woman who prior to this was community dwelling, lived alone, independently, did all of her own activities of daily living, took care of herself, went grocery shopping. She is amazing and highly functional. And she had a bout of pre-syncope that led to her presentation. So do you guys want to take a tackle at kind of approaching the chief concern, or do you want some history?
I actually think this is a great place to stop here. Deborah, do you want to take the first stab at this, and I can fill in afterwards?
Yeah, I was thinking about the pre-syncope. Like, I think a pre-syncope could be a sensation that the patient is going to fake, that the patient feels like some weak, that and don't really pass out. I think that could be a difference between syncope and that the patient really regain consciousness. So I would ask what the patient felt, if had any other symptoms, if how long it was, what the patient was doing, and if felt, I don't know, some confusion, dizziness, a blurry vision. And yeah, and I will, more than that, I will go like we always go for our loss of consciousness with the assays. I would make sure if it's not a syncope, it could be like something else. And yeah, I think we could go to for the loss of consciousness with the 7 assays that we have now with seizure, sugar, syncope, substance, psychogenic, and sleepiness. I think that's what I will start. I want to know more information and ask if she is with someone, or if she can answer, if she can tell me everything what happened with her. That's where I would start. Well, back to you, Maddie.
Yeah, I completely agree with you. You know, what you said, that here we're getting the information of pre-syncope, but I would maybe want to step back, exactly like you said, and consider other things that can appear like syncope. So the differential diagnosis of transient loss of consciousness. So syncope, as you said, seizures, like you said, even potentially a stroke or a TIA can present like this. So exactly as you said, considering some of the mimics of pre-syncope, and ways to make progress on that are to get a little bit more history about what the patient was feeling like before this episode of syncope that led to the subarachnoid hemorrhage, kind of intra and post. So did she have any kind of aura, as you said? Was there any kind of jerking of the movements or tongue lacerations that would make you think of a seizure? And then, you know, a very quick one to fix is, could this be low sugar? So I would definitely want to get a blood glucose very quickly. So I totally agree with Deborah with what you said there. And I think if we are thinking that this is syncope, you know, the way I like to think about that is there's a decrease in perfusion to the brain. And so you can use just think of the equation for, you know, blood pressure, which is cardiac output times peripheral resistance. So I think I'd want to be concerned, is this of a cardiac origin or not? But I think that's what those are the initial thoughts that are going through my head. It's interesting that it seems like this is a very big change from her baseline. Dr. Restrepo said that she lived alone, independent in all of her daily activities as a 90-year-old, and then all of a sudden had this episode of pre-syncope. So that stands out to me as something that's a little bit odd. It seems like this is a pretty, you know, she doesn't have a history of falling much, it seems. So it kind of stands out to me as something that's pretty concerning from her baseline. Ravi, any other thoughts at this point?
No, absolutely wonderful. I think you highlighted some very important points, but sort of summarizing what you mentioned, 3 things. Number 1, the DDX is pretty much similar to, like Shane had mentioned, all the DDX for syncope, so pre-syncope, pretty much the cause are the same. I guess one differentiating point is with in regards to postural tone. With pre-syncope, postural tone is maintained. With syncope, usually postural tone is not maintained, and one is transient with cerebral circulation. I guess the other one is the next step, the sort of like pre-syncope is a prodrome to it. So a transient versus a temporary reduction in global cerebral perfusion. Back to you, Dr. Restrepo.
Awesome discussion. So to be very specific, she did not lose consciousness. So she's pretty explicit about that. So you can't have syncope if you didn't really lose consciousness. A little bit more is that she tells me when I sit down to talk to her that it was really hot in her apartment that day. She had turned the heat up a lot in her apartment, and she had been sitting down. She tells me when I really pin her into being very explicit about what happened, she stood from a seated position and then felt very, very woozy, dizzy, and then sort of didn't lose consciousness, but felt her legs buckle underneath her after standing and then hit her head. And that is ultimately what prompted her to be brought into the emergency department. CAT scan of her head showed the subarachnoid hemorrhage that had her admitted to the neurosurgical service. She does tell me that somebody, meaning her doctor, had maybe made some medication changes before. So how does that help you in terms of picking your buckets?
Yeah, so I can take a stab at this one first. So I think the fact that there was no loss of consciousness and that she, stood from a seated position, I'm really translating this into orthostatic hypotension, which in my mind, how that presents is a patient stands, they feel lightheaded and potentially falls. And there are specific, I think, we could define it where I think it's a drop in systolic of 20 or a drop in diastolic by 10 upon standing. So that would, I guess we would want to kind of measure that, but this already happened. But if we just jump into kind of what causes that, the way I think about that is there hypovolemia of some cause? And it kind of all falls back into that equation that we talked about. So blood pressure being cardiac output and systemic vascular resistance. So if you are hypovolemic, you're not having enough stroke volume for that cardiac output. So hypovolemia, I think Dr. Restrepo said there were some medication changes. So I would be interested to see what those are, what her medications were previously and what they are now, because some medications like beta blockers or alpha blockers can affect how well kind of the peripheral vessels clamp down for the peripheral resistance that could be contributing to this. So yeah, I think of, is there hypovolemia? So any maybe history of lack of PO intake, diarrhea. I'm really interested in the medication changes. And then the other bucket that I often think of is kind of changes to the autonomic nervous system in some ways, things like Parkinson's and stuff. But I think I'm most concerned about the medication changes, and that's the additional info I would want to know. Deborah, what are you thinking after this information?
Yeah, I agree with everything that you said, and with adding the patient said there was a high elevation in the temperature. So I would ask if the patient, I don't know, is taking enough fluid, if it's feeling well, if had like, I don't know, some dehydration that could be a cause too. And yeah, I would investigate it. The medication, of course, and ask about the past medical histories, have some endocrine problem, heart problem, and I think that's where I would go for it. What do you think, Ravi?
Oh, absolutely. Both of you are right on point. And the one thing that sticks out to me is the warmth you had mentioned. So is it part and parcel of the symptoms, or did the warmth precede this? So vasovagal is a common cause of this. Plus the meds may have also been inciting this as well. So was there another inciting event like shock, fright, an emotional event, feeling warm, sweating? Maybe vasovagal could be a cause of something like this. Maybe she was also partially volume down. So these meds are very important. Is she on maybe also diuretic, or is there any issue with her heart rate? Can she compensate for hypotension? That we're kind of floating as a hypothesis here. So if she has chronotropic incompetence, like Madeline also mentioned, is she on a beta blocker and she's not able to raise her heart rate? Other things sometimes I think about with this dysautonomia that Madeline had mentioned. So there can be some neurologic conditions like Parkinson's, Lewy body dementia. You could also have multiple systems atrophy. So is there a neurocognitive neuropathy? Some people also alluded to in the chat, maybe there's some baroreceptor response. So there's many different things here, but I don't know. I really do want to visit that medication list to at least know where to start putting some emphasis on. Back to you, Daniel.
Awesome. So these are great points. So her medical history was very bland. She had a history. This is how you make it to 91, by not having medical problems. But so she had hypertension, and she had previously had a poorly characterized supraventricular tachycardia for which she was on amlodipine and metoprolol. And she had been reporting some palpitations, and so her docs had increased her metoprolol a few weeks back. Her family history in this 91-year-old is what I'm going to say non-contributory. She, as I said, lived alone, was a homemaker, had 7 children. She did not have any recreational tobacco, alcohol, or drug use. She lived, again, with supportive family nearby, but was totally independent, had no pertinent allergies. So do you guys have a smoking gun?
Deborah, you want to comment on this one first?
Yeah, I was thinking about the metoprolol that could be, if that could be the cause. I was thinking maybe that it could cause like this orthostatic hypotension. Maybe it could be a side effect, and or their arrhythmia. Yeah, I think I would investigate it more. And what do you think, Maddie?
Yeah, I'm, if this increase in metoprolol, I think could potentially explain the symptoms, because when we think of orthostatic hypertension and we kind of went through the pathophysiology that you kind of need to compensate for decreased venous return, and the heart generally does that by increasing the heart rate. And so if you are not able to do that, that could potentially explain this person's experience of pre-syncope. So I don't know if I think it's probably important to not anchor on that being the sole reason, and potentially make sure that there's no other contributing factors to it. But I think an increase in a beta blocker could be a reason for this person having the pre-syncope. And what's also interesting that stood out to me is the previous SVT, because a cardiac arrhythmia is another reason that someone could have. I know it's not syncope because they didn't lose consciousness, but I guess an arrhythmia is another reason why someone could have syncope or pre-syncope. So ultimately, I think we need to investigate the rhythm and the functioning of the heart. So getting an EKG or an echocardiogram after a physical exam is something that would be important in my mind. Maybe also asking her, I see people in the chat put like, did she feel any palpitations before or during this episode? That would maybe make us a little bit more concerned for this being of cardiac origin. Anything to add, Ravi, about or what's standing out to you?
Yeah, just 2 things. I really sort of gonna extrapolate from your physiological approach, but this heart rate, I think, may have something to do with it. So number one, I do see many people, even myself, sometimes I maybe take a multivitamin and I go back and I forget, hey, did I take one? Okay, let me take it again. And then I double up by accident. And this is common amongst our patient population. They may overdose. And I've had patients with beta blocker toxicity come in. So I'm very interested in seeing what the heart rate is. And that could easily explain this. And the second thing is, with the process of neurocardiogenic syncope, what usually happens, you start out with some inciting event and you have tachycardia, and the tachycardia then is halted by putting the brakes via the baroreceptor or the atrial stretch reflex, and then you get a vasodepressor response, so bradycardia and hypotension, and then the patient syncopizes. So SVT itself, these episodes could trigger this sort of a mechanism, and maybe loading up on the beta blocker may exacerbate this mechanism and then really cause this patient to have this feeling. But although she didn't really lose consciousness, she was pre-syncopal, not syncopal. So I'm just kind of wondering, I would wonder this to be quite catastrophic and not just a pre-syncopal event. Back to you, Daniel.
All great thoughts. I will just start by emphasizing that it was a singular episode. There was no palpitations, and it was strictly and explicitly postural. So there was I think all your points are very, very, very valid. But just sort of like, because all we have in syncope and pre-syncope is the history, right? We've been spending, at least in this country, $1 billion a year more working up syncope over the last 30 years, and our diagnosis rate has gone that much higher. It's because it's all in the story. So, it was a strictly singular episode, no palpitations, very much a postural event. So some people have been asking for orthostatic vital signs. So maybe we can move on to the exam, and I'm gonna tell you a little bit about my experience with examining her, because I think a lot of what had been going on to that point, up until that point, was I heard sort of very, elderly woman, beta blocker increased. It's hot in my apartment. Maybe she was a little vasodilatory from that. I stood, and then this all happened. My beta blocker had been increased. This was open and shut, in my mind, orthostatic pre-syncope in that moment. But I did my own orthostatic vital signs, and I encourage you all, when you're really worried about a patient, just do your own. And I will encourage you all to skip the seated part. That, I don't know who came up with that, but it's like nowhere is it written that you need to sit somebody up. So I measured her supine blood pressure was 110/70, and her heart rate was, let me just triple check, was 80 at that time. And then what you should do is not sit them up, but stand them up and check it immediately. Because really, if you are volume underloaded, if you are volume contracted, that's when you'll see the drop in blood pressure and the rise in her heart, okay? So don't let them equilibrate by sitting. I think unless they are very, very dizzy from laying to sitting, do not stop there and stand them straight up to actually interrogate what's going on physiologically. And I stood her up, and at that point, at 0 minutes, she was 105/70, and her heart rate went up to 88. And then if you want to see how their autonomic nervous system is responding to things, you can check it 2 or 3 minutes later, and her vitals were exactly the same. The confounder here, team, is that she had gotten, over the course of the preceding day, she'd gotten some fluid. So, and her antihypertensives had been held. So tough, it was a muddied exam in that sense. So whenever if you're seeing somebody in the emergency department, by the way, American Journal of Medicine study in 2005 asked, what is the single best test that will actually change your management in syncope beyond the story and the electrocardiogram? Is orthostatic blood pressure. Changes management 25% of the time. Our beloved troponin changes management 0.1% of the time. It's a terrible test in syncope. So if you're seeing somebody in the emergency department, or if you're in the first sort of person to go see that person, please do orthostatic vital signs before other interventions like medications or fluids or other things like that. So that's just a quick high value care plug. It changes management 25% of the time in syncope, and we don't do it quick enough. And then people get fluids or medications, and we don't really know what to do about it. So tough to say, but her orthostatic blood pressure was pretty unremarkable. The rest of her vitals were normal. I believe she was normoxemic. She had no fever. She wasn't hypothermic. And we'll get to the electrocardiogram in a bit. Actually, I'll give you the electrocardiogram right now, and I'll tell you sort of, and the story and why this became, and she did not feel dizzy when she stood up. The story of how we weave POCUS comes in the middle of my exam. So, but I will tell you that her electrocardiogram was notable for normal sinus rhythm with a 1st-degree heart block. And I'm going to give you, it's an impartial ECG, so that's all I'm going to tell you. Or an incomplete ECG, sorry. So I went on to examine her, and keep in mind that the eyes and the ears don't sense what the mind doesn't think about. And as I was going to see her, this was open and shut orthostasis medication. So in general, she was non-toxic. She was well appearing. She was interactive. Her HENT exam, she had dentures in place, moist mucous membranes. And I usually start my exam at the head, and I work my way down. And I look at everybody's jugular venous pressure. It's just habitual. I just do it. And again, with the story, I could convince myself that with the patient at 45 degrees, I saw a flicker down under her clavicle. And then I looked kind of higher up the neck just to sort of quality control myself. And I saw a flicker under her mandible. Now, at this point in time, I was confused, but I could convince myself that this was a monophasic impulse of a carotid. And I was with the resident, and the resident's looking at it, and I'm looking at it. Oh, this is just really, you know, it's probably, her filling pressures are probably not super high, but let's just confirm it. And I grabbed my probe. Now I'm gonna take over sharing the screen, if that's okay. How do I think somebody has to get out of the, oh, wait, share screen. Can I just mute the board for a second? Great. All right, so this is what I saw. Can you guys see this?
Yep, we can see it.
So for context, the probe is in the short axis. So this indicator, this B right here, is pointed to the patient's right. And we're looking at two blood vessels in the short axis. So since they're both tubes, they're just going to look like circles. Does that make sense? All right. So the probe here is what I will now, the person, I have now sat her straight up. So she is completely upright. And I put this probe under her jaw at this point. So she is now upright and the probe is under her jaw. We are looking at two blood vessels in the short axis, okay? Now, for those of you that haven't looked at a lot of IJ ultrasound, I'm gonna give you a little context. This is the carotid and this is the jugular vein. So here's the clip again. The big blob in the near field is the jugular, and the small kind of conserved circular blob is the carotid in the back. Now, a great pearl that came out of a paper that I read about a year ago was that in the upright person, the finding of a jugular vein greater than a carotid at the clavicle, mind you, not up here, but at the clavicle, is 95% specific for an elevated right atrial pressure. Meaning that if you have a patient that is upright and you put the probe on their clavicle, if their IJ is bigger than carotid through the respiratory cycle, remember that as I breathe in, my intrathoracic pressure goes down, my venous returns increase. So that's going to suck fluid and blood out of the neck and out of the IVC. So the IJ should collapse. But if it doesn't collapse and it's larger than the carotid through the respiratory cycle, that is, again, incredibly high positive predictive value for elevated right atrial pressure, for high CVP. Now, that doesn't mean volume status necessarily, but it just means that the pressure on the right side of the heart is very high. And this is now, and I actually, you can do what's called the sonographic JVP, where you actually try, you find the top of that column of blood in the jugular vein. And I will tell you, team, that I couldn't because her head was in the way. So like all I could get up was here. So I actually have not seen the top of the JVP, which means that her right atrial pressure is bananas high. Okay. So I'm going to go back to what I said earlier, is that my exam of her heart became a lot more focused at that point in time. And when I listened closely and I palpated closely, I felt this. And I heard this. So what do you all think? Maybe we'll pause here. I have a few more pictures, but maybe she has no peripheral edema, no organomegaly on the rest of the exam, and then her lungs are clear. That'll complete the exam for it. So maybe we can pause here for a sec and I have more slides and I'll show you more pictures, but how does this change your differential diagnosis?
Yeah, okay, I can take a stab at this. So first of all, that was just a great pro. I did not, realize how useful that test was for the, the jugular vein being larger than the artery there. So exactly as you said, we know that there is elevated right atrial pressure here. And so the question is, why is there elevated right atrial pressure? And then you said on the exam that there was, I think if I read it correctly, there was like a holosystolic murmur at the left lower sternal border. Is that right?
Low pitch.
Okay, so to me, that could be consistent with tricuspid regurgitation. And that in itself could explain the elevated right atrial pressure. I think you also said there was a loud S2. So to me, my mind is jumping to, is there, I don't know, pathology in the pulmonic valve? I believe you can see like a loud S2 if you have, pulmonary hypertension or, so that's what my mind is jumping to a little bit. But I think what I am anticipating seeing in the echo is some aspect of tricuspid regurgitation, which could explain the holosystolic murmur and the elevated right atrial pressure, and maybe some aspect of pulmonary hypertension causing the loud S2. Yeah, Deborah, what do you think about the information we got?
So really nice pearl from what you explained for us. Thank you so much. So yeah, I was thinking about the loud S2. It could be a pulmonary hypertension. It could be something in the pulmonary. And that's my thought that was, but in what type could be like type 2 maybe, because we are talking about something maybe during the tricuspid valve. So yeah, but the patient doesn't like had pre-syncope. I don't know. I need to think, but I think that maybe I will think about a pulmonary hypertension and try to find the cause. I think maybe. Yeah. What do you think, Ravi? You that it's a cardiology expert.
That's just wonderful. I'm sort of going along with what you're saying and sort of piecing it together. If you put together what you've mentioned, Madalena did a great job going over what this could be. We're in the tricuspid regurg area, then this loud S2, what that could be. So maybe in the pulmonary or the pulmonic valve. And then I just wanted this right ventricular, was it, Daniel, the right ventricular heave? So putting your hand along the left parasternal area, and with each systole, you feel a heave. So that means to me that there could be right ventricular enlargement. So putting that together, the pressure dynamics from the pulmonic circulation and then through the pulmonic valve, right ventricle, and then you get the JVP and the tricuspid regurg is possibly secondary to increased pressure in the pulmonary circulation. So what is going on proximally in the pulmonic circulation that's causing all these downstream abnormalities? So I think that's where we're kind of focus in on. So probably need to elaborate on what the DEX would be that would cause all these dynamic changes in the heart.
The other morsel I will give you is that she had low voltages on her electrocardiogram, borderline. So typically, just for reference, you should have your voltages should be larger than 5 millimeters in amplitude in the limb leads, and on the precordium they should be larger than 10. So and she was around like 6 and 9 and 5 and 8 in those ranges. So she had borderline low voltage right there. All right. So then after auscultating, I'm going to apologize, and I see Dr. Dancell's on here, so please apologize for my very brutish images, but I'm going to, these are not great quality, but I got enough to sort of, to really start to get my feelers up for what I thought was going on at that time. So I'm going to share screen again, and I'm going to go back to here and show you guys this. So we had the exam, and here is what I will grab the probe and we'll play this clip. So this is a parasternal long axis clip, which means we're slicing the heart down the long axis as the heart is a pyramid that lays in the chest, right? And then I'm going to rotate 90 degrees in the parasternal short. So we're basically going from slicing a heart from kind of like how you would slice a hot dog bun then rotating it and slicing it like you would slice a loaf of bread. And that's what the clip is going to show you.
And
Now, I think the clip is best in the short axis view, which is what we're viewing right here. But maybe Dr. Dancel, since I see her camera on, maybe she can, as probably the greatest POCUS expert here, tell us what she sees. Maybe I'll start the clip over.
I was going to tell you your images are beautiful. You do have it on presenter mode, so we can kind of.
Oh no.
I don't even have to be good. I just like, it says dilated RV. No, but I think people in the chat did talk about the rule of thirds on the peristernal long, which was a good pickup.
I'll
And
turn off presenter mode. This is what happens when you don't use your own computer.
so on the peristernal long axis view, your right ventricular outflow tract, the left ventricular outflow tract, and the left atrium should all take up about a third of the right side of the screen. And so someone astutely picked up that the RVOT looks a little bit big. Always take that with a grain of salt, though, because you're basically, as one of the people that I like to teach with says, you're seeing the chimney of the right ventricle. So it's just a very small piece of it. Having said that, that short axis view is also pretty telling. And let me see if somebody said something about the bagel and croissant. That's what I call it.
Oh, that's what I call it. I didn't know that's what you called it.
Yeah. Makes me hungry every time I teach it. What do y'all think of the septum on that short axis view, though?
Right there.
Oh, getting bullied, right? That bagel doesn't look so much like a bagel. It should, but part of that bagel is getting punched by the RV. So that's what the RV heave is all about. So there's either a pressure or a volume issue on the right side. It could be an and, so it could be a pressure and a volume issue on the right side of the heart.
So taken in concert, these things really just showed a very dilated RV with, as Dr. Dancel said, either pressure and or volume overload. Okay, maybe we'll pause there because the rest of it is not POCUS, but I do have some data points to show you all. But maybe how does as you're thinking about this, I saw in the chat some things on the order of like what kind of things can give you low voltages, like a pericardial effusion. Now we got 2 limited views of the heart there. There wasn't, I think, a big enough effusion to explain low voltages there. So, and I told you that her lungs are relatively normal. She's a never smoker. She's a relatively thin person. So that whittles down the list of kind of to maybe a muscle problem itself.
I'm going to take a stab at that. It's kind of a fascinating constellation of findings on the EKG, but usually, like Daniel mentioned, when the electrodes are removed from the chest, if there's any sort of, defacement of the interface between the heart and the electrode, so you could have like fluid, like Daniel had mentioned, a pericardial effusion or tamponade. Could there be fat? Could there be air, like COPD? Emphysema, pneumothorax could also do that as well. Then you have these findings or grouping of findings called infiltrative cardiac disorder. So we had a very good case discussion with one of the programs where there was cardiac amyloidosis. Mixed edema could also be a cause, hemochromatosis, scleroderma, constrictive pericarditis. So a couple of things. And then you can have a really, really diseased, a really bad heart, an end stage heart that could have just very poor myocardium, I guess, or ability to generate voltages where you may get a low voltage on the EKG. So those are a few thoughts that I had. Madalena, Deborah, anything else you'd like to add?
No, I love that. One helpful way I've heard low voltage being described is the heart normal, but something is preventing the voltage from getting to the skin. So exactly what you said, like adipose tissue, or even like, air from COPD that could be preventing the voltage from getting to the skin, or exactly as you said, there's something kind of intrinsic to the heart that's causing the low voltage. And so something that's replacing the tissue, and as you said, like amyloid and other infiltrative processes, or even like an ischemic event because there would be less heart tissue. So that, there was, from the images we've seen, no signs of pericardial effusion. I don't think anything was commented on the physical exam about being there, about there being a lot of adipose tissue. So maybe it's something more about there being less cardiac tissue itself, and maybe like an infiltrative process could be what's going on.
Amazing. So we recommended that a full transthoracic echocardiogram with what's called strain protocol, which is when one is suspicious for amyloidosis. We requested it, and basically I will give you the results of the echocardiogram. So she had mildly reduced LV function with left ventricular EF of like 46%. She had biventricular hypertrophy on the full consultative study. She had a right ventricular systolic pressure of approximately 82 millimeters of mercury. For those of you that are unfamiliar with it, basically the echo folks that get the echo measured the amount of tricuspid regurgitation, which in her case was severe, and they use that to sort of estimate by some math what the pressure inside the pulmonary artery actually is. This is abnormal is between 30 to 40, so this is markedly elevated. She, as I mentioned, had that severe TR that we heard on exam. There was evidence of RV pressure, RV volume overload. Her RV systolic function was very, very poor. And again, as I mentioned, she had biventricular hypertrophy. And because of her age and because of her overall phenotype in general, we were actually most concerned about wild type AA amyloidosis. And so I seen in the chat, I believe it was Shema said, that talked about we had sent an SPEP with light chains which were normal. She had no proteinuria, but we did obtain a non-invasive test that can actually be highly suggestive of the diagnosis, which is called a calcium pyrophosphate scan. And I see another, no other neuropathic symptoms, no bilateral carpal tunnel, no glossomegaly, no bicipital tendon rupture, bicipital tendon issues, which you can see with amyloidosis in these in people of this age. And her calcium pyrophosphate scan is, I have the pictures if you guys want to see it, but it was read out as highly suggestive of TTR amyloidosis. So that's it right there. So I guess, and if I'm kind of mid-career in POCUS, I am a total neophyte when it comes to looking at nuclear medicines. I have no idea, but I'm fairly certain you shouldn't be able to clearly see the outline of a heart when you put in a calcium pyrophosphate scan in here. And hers, you can very much see it. So this actually gave us a diagnosis of wild type, which is formerly known as senile AA amyloidosis, which is transthyretin amyloidosis.
Wow, that's absolutely incredible. I just put in the chat that the diagnosis was very conveniently outlined by you earlier, but then you didn't just stop at it, but you kept going and not performing premature closure, and you actually got to a DX, which is just astounding. So the lesson I've learned here is not to, if a diagnosis is very convenient, to challenge it just to make sure you're not missing something. And this is an absolutely phenomenal case. I don't think there was anything outlined initially. Maybe these pre-syncopal. I did have a patient that presented with syncope, and it was a manifestation of amyloidosis causing autonomic dysfunction. So it is it is in the DDX when you have to consider, and you may not always have, like you outlined, the other features like renal involvement, carpal tunnel syndrome, and so on. So phenomenal case. I just learned a lot, and something to think about in a patient like this. Just not to stop the workup, but challenge yourself every day. Madalena, Deborah, any reflections on this?
Yeah, Dr. Restrepo, I just want to thank you again for presenting this case. I think, as Ravi just said, what really stands out to me is how you kind of kept pushing to go to the next step and asking why. Like, even at the beginning of the case, there were some signs that could have pointed to a reason for why this person had what seemed to be orthostatic hypotension, like the medication changes. But then when something didn't add up like that, you kind of pushed to the next step. And then when you got the signs, like kind of the POCUS signal on the jugular venous exam that pushed you to examine the heart more. So I feel like it just is such an amazing example for all of us about how, as Robbie said, to not prematurely close and kind of like following your curiosity, like taking it to the next step and investigating, well, why is this exam more abnormal than I was expecting? So I really learned a lot discussing this, everything from pre-syncope to orthostatic hypotension to low voltage on EKG. So really, I learned a lot, and thank you so much for preparing this for us.
Thank you for having me. I think the couple points. One, and I think I've said this before, but I think that there's like a lot of power. Obviously, I think that why is the most unbiasing question that we can ask as internists is like, why is the potassium low? Why is it like that? Is I think the thing that will keep us the safest. The other point is that I think that there's a lot of power in observed versus expected. So I am hearing orthostatic, I am hearing all of these things, then her filling pressures should not be crazy high. Or if they are this high, then I need to think about that rare cause of what's called preload dependence, right? Folks with amyloidosis have preload dependence. They can't actually augment their stroke volumes well, and they need large amounts of preload. So if she venodilated and she had more pooling when she stood up because it was hot, that's maybe it was enough to tip her into hypoperfusing, right? So like that's the rare cause of like high filling pressures and orthostatic hypotension. But like observe versus expected, I'm expecting her to be down here. If I see something up here, that's weird, right? And so you should listen to that dissonance, because it's really easy to brush off dissonance because it's what we call confirmation bias, because it doesn't fit our impression. So to me, I think observe versus expected is always super powerful. The other point is that I think, and I've actually seen Dr. Dansell speak about this, but I think that many people are very dichotomous, falsely so, about POCUS and the traditional exam. But the fact of the matter is that there's like an amazing crosstalk between the two of them. And I think that this was a great case where like, if I hadn't looked at her neck, I wouldn't have grabbed a probe. And if I hadn't have grabbed a probe, I wouldn't have listened as closely as I did. And I wouldn't have looked as closely as I did at her heart. So there's such a like a symphony of conversation between the two of them, because it is a part of our exam. There's like philosophical battles about this, but I do believe it's a part of our exam. It's just another bedside tool, just like your reflex hammer or your pen light or anything else. So that's the other point. And the last point that, and this is about like anything from reading a chest x-ray to a CAT scan to an EKG to examining people, is that you'll save way more lives by being thorough than by being smart. And I do firmly believe that. So those were like the big lessons, because there are like many situations where we would have walked out of that room just saying that this was beta blocker and a little bit of heat and then the little old lady, and then we're done. So I actually remember this case now because it terrifies me, because of, I may have just done that that day. And I see a question about how do we explain the pulmonary hypertension? So folks with amyloidosis have usually chronic multifactorial pulmonary hypertension, but it's often group 2. You can have pulmonary involvement of amyloidosis, and it usually manifests with pleural effusions and ground glass opacities and things in the airways, but it's typically here in this case due to an infiltrative cardiomyopathy, and for reasons that maybe smarter people can tell you than me, but there's often a lot of basically it's a lot of restriction, and the right side is predominantly affected a lot of the time. So these folks have a lot of RV issues.
And then one question I had is what is the management or treatment like with this patient once you determine that it was TTR amyloidosis?
So the other reason, it used to be that we would just do this in the old internal medicine, this is what you have, there's nothing to do about it. More recently, there's been a drug that actually has improved, has delayed progression of cardiac amyloidosis. It's a very expensive drug. It's called tafamidis, TAFAMIDIS, I believe. And it's been shown to slow progression of the disease, so that if you catch it early enough, folks can actually live longer with this disease. It improves their 6-minute walk test. So there are some patient-centered outcomes that are associated with it, not just making like a cardiac MRI prettier so that the cardiologist can publish a paper. So there are patient-centered outcomes that actually are improved with that drug, which is why it's now, I would say TTR amyloidosis is an underdiagnosed disease. There you go. There you go, Robbie.
I do have a question, Dr. Restrepo.
Sure.
So why does it always have to be like in the right side? Is there like some sort of
that's the part where you're going to need someone smarter than me to tell you that. But I just do know that phenotypically folks with amyloid cardiomyopathy have a disproportionate burden on the right side of their symptoms. You'll see them coming in a lot more with, not with left-sided heart failure, but with right-sided heart failure.
Thank you, Dr. Restrepo. That was fascinating, and the teaching was spectacular. We should go on to teaching points. I think, Joy, you're doing the teaching points today.
So we have a really good discussion here today. A really awesome VMR with a POCUS focus VMR, which is like trainees like me really love the POCUS, learning POCUS. So thank you, Dr. Restrepo, for coming today and sharing all your amazing pearls in this case. Also very awesome case. So very quickly, this patient, elderly lady in their 90s, but it's like she's one of the few that is highly functional as far as the ADLs, and she lives alone. She can obviously take care of herself and doesn't need assistance as far as ADLs. And she's coming in for episodic or multiple episodes of syncope, or more likely when we dig into more of the details, the history, it was more of a pre-syncope, and there was no loss of consciousness. And so in thinking about syncope, we think of right away our system one thinking, the 4 S's, you know, as far as etiologies, could it be like we think first of anything, the first thing like we think about is cardiac causes, right? Cardiovascular, to be specific. That includes arrhythmias, valvular, and extracardiac. That includes the pulmonary, anything in the brain, and we also have to think about the reflex causes of syncope, such as the pretty common, actually, the vasovagal syncope. Also, like in this elderly patient, we also have to think about thick carotid sinus. Like the baroreceptors there are very sensitive to slight pressures in the area, in the neck area, that could set off this sensitivity to the whole reflex happens and causes them to syncopize. So, and there was also a thought of could possibly be positional, as the history described here, what was happening at the time. And obviously we have to also dig deeper into like what happened when they were having these episodes, like as far as was there a prodrome of some kind, which we had in this case, like the patient described like having a warm feeling, but they were not dizzy. And but they did not have loss of consciousness, which is very important clinical findings to describe that this was not actually syncope if they did not lose consciousness. So since this is a POCUS VMR, so it's few things to put into consideration here, that as our expert here, Dr. Restrepo, very in so many words explained and stressed that POCUS VMR is definitely just one data, right? Like in the a good history and a good clinical eye, you know, like really not closing your mind, but being a true, like we're in medicine because we like science, right? Like a good handling of data as they come, you know, not being not being like so focus on what you think should happen, like box in things like we tend to do when we know when we have our own already differentials in our head. That's a tendency there. But this is probably one of the best thing that I heard today from a clinician, from a seasoned clinician like Dr. Restrepo, that we should keep our minds open like this, like, and handle the data, honor the data, you know, as they should be taken seriously, equally. So so that's what he did. And so as far as like as a trainee, POCUS, obviously we have to think about the landmarks, right? As far as like, you know, they did a parasternal long and short, parasternal short here. And also seasoned clinician would tell us that when you're actually doing POCUS or interpreting a POCUS, when you're doing that, you should have a narrow question, right? Like versus a more general question. Like a narrow question would be, is there like a left-sided hemothorax here or a left-sided pleural effusion, versus like going there and doing a POCUS and you don't know what you're trying to, you have this so many questions in your head, right? So you would be able to find out what's going on, and you just subject the patient to more radiation, more tests that they don't really need. So so we found out that this patient had during the parasternal views, we started at the parasternal long, or it started out as like, what was that first one? Was we saw the very dilated JVD, and Dr. Restrepo told us that obviously like you have a very large JVD, so it's almost like you know, there is elevated right-sided pressure, elevated CVP here, and the specificity for that is very high, 95%. So obviously in the right clinical context, again, POCUS is just one data among the data that we look for and, you know, take into consideration. So so that's that. And then we went on to try to explain that enlarged JVD, and then we see the right-sided high pressure here in our patient. And then they talk, we incorporate the other findings, the physical findings of a right-sided heave and tricuspid regurgitation on our other diagnostics, and of course the low voltage limb leads, which kind of like what was also seen in this patient, although borderline. And what was a great peril here as far as like the like quickly, you know, the rule of thirds for like a parasternal long, the structures there that we're trying to look at, the chambers should be the heart chambers should be at least equal in dimensions. If you know, something is larger or narrower, so there's some abnormality there. So I'm a learner, so I don't know, I can't elaborate on that. And the parasternal short was more, this is more giving us a more detailed view on what we are trying to find out. So there was a really it further confirmed that the right side, the right heart is really the what was wrong here, the pathology is concentrated. And then they went on to, our discussants told us that went on to investigate what could or think of the top differentials for etiologies here, definitely the infiltrative etiologies, given that this is a right side heart, and Ravi told us that that would be top of the differentials there would be granulomatous autoimmune stuff in, of course, amyloid, and of course, if you have an end-stage heart disease already, and then of course, like amyloidosis rises to the top of our differential, and then Dr. Restrepo told us that there is such a thing as a more like a more focused investigation to rule out amyloidosis, which is like a strain protocol I haven't heard before. So that was done, and it was yeah, it was confirmed that this was like a TTR amyloidosis, senile, which was Dr. Restrepo kind of expected here for this patient's profile, and yeah, so that was that. And
Yeah.
Joy, thank you for the teaching
thank you so
points.
much. Sorry, we are a bit out of time. So yeah, thank you so much, Dr. Restrepo. It was a pleasure. Thank you so much, Dr. Ria. I said in the chat, but you are always ready to be with us and present a case. And next week, we are going to have Sanji with us. So yeah, thank you all. And I hope to see you in the next episode.
Thanks. Awesome job discussing, and always a pleasure. Thank you for Dr. Jansel's help, and congrats to our discussants. And thanks to everybody in the chat.
Thank you.